So, good evening, everyone. My name is Heidi White, and I am the Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate our wellness speaker series, including tonight's presentation, Understanding the Menoverse, a brief guide to menopause transition with Dr. Maia Sharuk. Dr. Sharuk is a Massachusetts native who did her undergraduate work at Wellesley College and medical degree at the University of Massachusetts. She completed her residency in OBGYN at Bridgeport Hospital, Yale New Haven Health, and then returned to Boston, where she worked at Atrius Harvard Vanguard as a general OBGYN from 2015 to 2022. She joined the ASCOG division at Beth Israel Deaconess Medical Center in 2022 and credits her mentor, Dr. Martha Richardson, for sparking her interest in menopause and women's midlife health. Her goals include providing care to patients during the menopausal transition, as well as improving education for healthcare providers and women's midlife health. So just a few housekeeping items before we get started. This is a webinar format, so we can't see, we can't hear you. We'll be using the Q&A feature located at the bottom of your screen so that you can type your questions. And we'll be answering questions throughout the presentation, and Dr. Sharuk will save time at the end of the talk as well. And with that said, Dr. Sharuk, I'll turn things over to you.
Heidi, thank you so much for the lovely introduction. As Heidi said, I'm Maia Sharuk. I am a obstetrician gynecologist at Beth Israel Deaconess Medical Center, and here to barely scratch the surface on understanding the Menoverse today. Just to briefly go through my disclosure, sadly, I have none, but I would like to credit my mentor, Dr. Marcy Richardson, both for my own educations and as well as some contributions. Just a little special note here, I may at times use the term women to reference any patient that has ovaries in this presentation. I do apologize ahead of time if I do switch between using patient and a non-gender neutral term like women, but please be aware that everything that I am referencing today includes anybody who was born with ovaries. So my objectives to go through today, again, I am going to stress I am barely scratching the surface today, but I'm going to review some definitions of both perimenopause and menopause. I am going to review some symptoms you might experience. I'm going to discuss some options for managing menopausal symptoms and hopefully provide some resources that may help guide in how you may approach a provider or goals for your own care. This little graph here at the bottom, I just thought was amazing. The PubMed search for menopause from like 1950 to today has just like skyrocketed, which we're so excited about. We're glad that people, both providers and patients, are finally getting interested in understanding this incredibly difficult transition that we go through. So I'm ready to kind of get into that. So I'm going to first talk a little bit about perimenopause. What is it? When does it actually happen? The old view for perimenopause is a little bit different of what we about think about now. Historically, we kind of thought that the first thing that people notice during perimenopause is like very noticeable changes in their menstrual cycle. We thought that the age of onset was probably in the late 40s, and that symptoms really were like hot flashes and night sweats and sleep problems. But we're actually understanding that there are a lot of different things that are actually happening. The menstrual changes can be very subtle, where you could have very slight changes in how long your cycle is, how long and how much you bleed for, could be going from a couple of days shorter, a couple of days longer. It may start as early as someone in their late 30s or early 40s. And the symptomology is much wider. It can include feeling mood changes, forgetful, irritable, tired, nervous, anxious, depressed. It just goes way beyond just hot flashes and sleep problems. The Menopause Society, which I am a part of, actually really started to change the definition about what perimenopause really may start to be, what patients may experience. In the beginning of perimenopause, most of the time the changes are extremely subtle. Patients may notice that their cycles are just a tiny bit shorter, may have gone from 28, 30 days to 25, 26 days. The number of days of bleeding may be a little bit more, maybe a little bit less. The flow may be a little heavier, maybe a little bit lighter. And as perimenopause kind of progresses, the changes in the cycles may vary as more to 7 days or even longer than that. And then we kind of figured out trying to understand what are patients really experiencing in this phase. Because again, it goes way beyond just hot flashes and night sweats. Patients may come in and talk to me and say, you know what, I'm not sleeping like I used to. I wake up at like 2 or 3 in the morning and I can't get back to sleep. I'm getting new feelings of anxiety. I can't cope with my everyday activities like I used to, and nothing has really changed. Patients will complain to me, I've become more irritable. I'm snapping at my family, and this is just not who I am. And so, is this perimenopause? Is it not? Does it matter if somebody is in their 40s? Are they 38? Or are they, older than that? And what if our periods have not changed? Does that mean I'm not perimenopausal and something else is going on? And so one of my great colleagues, a couple of my colleagues run this amazing site called Women Living Better, which I'll give a little bit later. And they have provided a lot of really great research that is survey based about understanding what people are noticing in their late 30s and early 40s into the mid 40s, and their experiences when they notice some of these symptoms and what they've noticed when they've tried to go and reach out to healthcare providers. Um, we asked them, like, how did it go? We got over like close to 1,000 responses, and we asked patients whether they felt satisfied or dissatisfied. And this is the like main caveat that we saw. We saw that patients are getting dismissed, talking about their perimenopausal symptoms. People will describe getting dismissed by multiple providers, and it doesn't take till they get to speak to someone who's a hormone specialist that they're actually getting the help they wanted. They may have spoken to a general OBGYN about their mood swings or sexual changes, and they felt completely blown off and told, I'm too young to be perimenopausal. And then some patients were told by their PCP or their gynecologist that it was hardly worth discussing. And this for us menopause providers, just like it's heartbreaking and kind of like angering a little bit because we know that this transition is really difficult to go through, and it starts way earlier than we ever expected. So, there was another survey that was done that looked at patients who were starting to notice very subtle changes in their cycles. And these are all the symptoms that patients were kind of experiencing: forgetfulness, irritability, low libido, fatigue, anxiety, skin changes, waking up in the middle of the night, feeling overwhelmed. And of course, we think about the night sweats and the hot flashes. But I mean, looking at this, I mean, night sweats and hot flashes are towards the lower part of the list. We have people who are complaining of more other symptoms than just hot flashes and night sweats. And so when do we really think perimenopause begins? It's when you guys have noticed a change. I think that is what is really important to know. If you notice that your body is changing, whether it's from your menstrual cycle or symptoms that are just not like who yourself really is, then it's time to talk to somebody because you shouldn't have to go through that. And then, as I mentioned, sometimes it's really before people will notice any changes in their menstrual cycle. And so I know as myself as a clinician, for researchers, we need to listen to our patients, learn how to support them, and talk to them about some of the options that we have for management that I'm going to talk about, maybe a little bit more reference to postmenopausal patients, but it really also applies to perimenopausal patients as well. So I'm going to shift gears a tiny bit and talk a little bit more about the actual menopausal transition and a little bit about hormone therapy. I'm just going to go through some important terms that I am going to be using kind of interchangeably. And I think semantics do matter for us because it's understanding what our goals are for managing our menopausal transition. So what menopause really is it is unfortunately a natural process, and it's really defined when our periods have fully stopped. And we kind of define that by having a lack of a period for more than 12 months. Okay. And this is really due to what we call a loss of ovarian follicular function. And that's just really the fancy term, meaning that like we are not producing kind of that reproductive cycle, producing eggs every month. If you see me refer to something called the FMP, that refers to the final menstrual period, meaning the last period after somebody then goes through for a full year after that. Premature menopause is defined as anyone who's had their final period before the age of 40. Early menopause is the final period before the age of 45. And when we talk about menopausal transition, we're really just talking about the time frame around menopause that's marked by those cycle changes, menopause related symptoms, and that transition technically ends once you've hit that 1 year of the lack of periods. And then we now enter that postmenopausal phase. A couple of other things that you may hear me refer to through this, and that is the kind of evolution name of hormone therapy. The term hormone replacement therapy is what is most commonly known about hormone therapy. We in the kind of menopause community have kind of largely replaced this with the term called menopausal hormone therapy. And this is really to reflect that the goal of menopausal hormone therapy is really to treat symptoms that patients are struggling with during the perimenopausal and menopausal transition, rather than just trying to get people back to their premenopausal levels. Hormone therapy is just kind of the overarching term, includes both hormone replacement, menopausal hormone therapy, and even some forms of contraception that may be used for non-contraceptive reasons. Menopausal hormone therapy, which is going to be the focus of what I'm going to get into, is what we formally think of as hormone replacement. And this is really to the use of estrogen in particular, with or without progesterone, to treat menopausal symptoms. When we talk about hormone replacement therapy, this is when we're actually talking about replacing needed hormones that are inappropriately low or missing. So we think about those patients who may have gone through menopause prematurely, whether that's because of surgeries that they had to have their ovaries removed, or they went through premature menopause as opposed to that natural age of menopause, or average age. So as we kind of mentioned a little bit with the perimenopause, I just want to talk a little bit about menopausal symptoms. And again, this is a work in progress. This only lists some of the symptoms that people may be experiencing. And we are learning day after day that there are other symptoms that patients really do experience during their menopausal transition. You will hear me refer to what we call vasomotor symptoms. This includes the classic hot flashes and night sweats, irregular periods, vaginal symptoms such as vaginal pain, dryness, which is also known as the genitourinary syndrome of menopause, sleep changes, mood changes, cognitive changes, or brain fog that many of us know it as, weight gain, low libido, thinning hair, skin changes, the joint and muscle aches of menopause, and the one that patients constantly describe to me is just not feeling like myself. I'm going to take a few moments to talk about some of these symptoms in a little bit more detail. Again, I'm not going to be able to go through every single one, but know that all of those symptoms are very commonly seen in menopause and should be brought up with with your provider. So let's talk a little bit about the vasomotor symptoms. So this is the most common and most for lack of a better word, obvious symptoms related to menopause, both for not just patients, but also for a lot of clinicians. And this describes what we call our hot flashes during the day and night sweats. Hot flashes and night sweats are often not just come on with temperature changes. Really, people also feel additional symptoms with it, accompanied things like extreme sweating. You can get a rebound chill sensation. You can have like a sense of anxiety kind of rushing through, feeling nauseous, and even heart palpitations. And really the hallmark of these hot flashes and night sweats where this heat change comes in very suddenly. It is an intense sensation occurring in the upper body, in the neck, chest, and up into the face. And then it can last anywhere from just like half a minute to like 5 minutes or more. They tend to be the most bothersome during the late perimenopause phase, as well as the early postmenopausal phase. And this is really when the estrogen levels really abruptly start to come down. Estrogen is a very, very important part of in controlling certain areas of the brain. Um, Specifically not only the parts that regulate our reproductive system, which just so happens to sit right next to our thermal regulation system. And estrogen really does a lot about controlling that thermal regulation system so that it's not always just firing, firing, firing. And when our estrogen levels get really low, now that part of the brain is just kind of not regulated, which is why patients who go through menopause are getting this like firing of these nerves within that part of the brain. And so this is where estrogen really plays a big role. The next most common symptom that patients will experience are really sleep disturbances. It can start off very subtle and then become extremely disruptive and can actually then worsen a lot of the other symptoms that are associated with menopause. So this can be both a combination of like difficulty sleeping as well as like the actual disorder of insomnia. Patients during the transition, we do know that patients who have the hot flashes and night sweats are even more likely to have disrupted sleep as they're waking up, drenched in a sweat or feeling very hot. But patients can actually have sleep disturbances even in the absence of hot flashes and night sweats. One of the main studies that was done across the multiple centers showed that almost close to 40% of patients between 40 and 55 years old report difficulty sleeping. And it is most common again in this late perimenopause phase as you approach the transition, and very, very disruptive for patients who may have undergone surgical menopause at an early age. Cognitive changes is also one of the most common things that patients come to talk to me about, which is the brain fog. We do know, again, estrogen is a big player in our brain, and patients really notice it, especially in the late perimenopause, and it is close to the right after the transition. People notice just this kind of like decline in like processing speed, memory, word finding problems, ability to like retrieve information that may have been given to them, and concentration. Interestingly enough, though, learning new information or responding to that information in the moment seems to be less affected, but it's really about that kind of recall or finding that like word on the tip of your tongue or walking into a room where you like, oh, why did I come into this room again? And forgetting why you're there. The only good thing I can say about this is the vast majority of patients do notice that after those first kind of several years of the menopausal transition, this does seem to level out. And so that it is not a continuous problem through that kind of remainder part of the postmenopausal lifetime. The next thing that patients may also kind of talk about or you may be experiencing is what we call the arthritis of menopause. This can be anywhere from just like muscle aches, joint pain, worsening arthritis, and more than half of patients will experience this. We do know that if we're a little bit more active or have a little bit extra weight on our bodies, it does seem to be a little bit harder on us. And we know that this is because estrogen has a very big role in cartilage metabolism, balancing the inflammatory reactions that happen in our joints. And when our estrogen levels kind of decrease, all of that is just not protected there. Skin and hair changes are also really common. Estrogen plays a big role in maintaining certain parts of the structure of our skin cells. And so patients will describe having worsening dryness, itchiness, thinning of the skin, wrinkles, difficulty with kind of the wound healing if they cut themselves, pigmentation changes in the skin. And I mean, a high percentage of patients will notice this. And of course, it affects our self-esteem for some of us. And so, again, it's not just aging alone. It may be a little bit worse during that menopausal transition. So, I listed some of these symptoms, got to go through a few of them. But let's talk about a little bit what we can do about this. And I'm going to first start a little bit more so on the hormone therapy side, and then I'll get a little bit into some of the non-hormonal options. So, Right now, technically, menopausal hormone therapy is FDA approved for the following reasons. The first is vasomotor symptoms, so our hot flashes and night sweats. It is FDA approved for the use of bone mineral density loss or prevention of osteoporosis. It is not a treatment for osteopenia or osteoporosis. The downside to it is that it's only good while you're taking it. So as soon as you stop the hormone therapy, that protective effect is gone. It is also used for the treatment of like the early low estrogen dropping. We're thinking about patients who've had their hormone ovaries removed for genetic or surgical reasons, premature menopause. And lastly, it's also FDA approved in the vaginal forms for what we call the genitourinary syndrome of menopause. That being said, just because it is not FDA approved, doesn't you don't fall into that FDA approved, category, it doesn't mean that you are not a candidate for menopausal hormone therapy. And one of the main philosophies that a number of us have is individualizing therapy because patients will struggle even without these conditions, and you should not have to struggle in silence. So, if I can say anything or any takeaway message is you really need to have a conversation with your provider, understand what your goals and options are, and know what may work best for you, or trying something that may work best for you. I think it's also important to really express what your goals are and know that there may be some limitations on what be able to get fixed with hormone therapy. But just because you don't have hot flashes and night sweats, it technically doesn't mean that you are not a candidate. And it's really about having that conversation. And if your provider is not ready to talk about that or doesn't feel comfortable talking about that, finding somebody who is, because not everyone's menopausal transition is the same. And again, you should not have to struggle through it. So I'm going to talk a little bit about the types of hormone therapy that are available. The first is we're going to talk a little bit about estrogen therapy options. Okay. Estrogen alone is done for patients who have had a hysterectomy. Oh, I apologize here. I apologize, guys. I think I just, my
No worries. Take your
engine
time.
got, let's get back to talking about the types of hormone therapy here. I apologize, Heidi. I think I need to reshare my screen as
Yeah, go for it.
I
Let's
think
see.
that's, let's see here.
Yeah, I think you
Yeah, I
should
think we
just be
needed
able
to
to
do,
do that.
yeah,
There you go.
here we go. I'm not
Awesome.
sure why that closed, but I apologize for
No
that delay.
worries. Must have been the thunderstorms.
Oh, maybe. All right. All right. So, as I was mentioning, we were talking about a little bit of the types of hormone therapy. Okay. So, estrogen therapy, when done alone, is really typically only reserved for patients who have had a hysterectomy. More commonly, it is a combination of both estrogen and progesterone. There are some opportunities for progesterone alone if needed. And then I have listed these two other forms that are a little bit more nuanced about kind of like very selective estrogen modulators that I'm not going to spend a ton of time on, but I wanted to at least list them here. So if you are in a little bit of a different category or high risk category, you may have some additional options that, especially if you may not qualify for estrogen alone. But that is a conversation for sure with a menopause specialist. So, in terms of the estrogen options that are available, and this is for estrogen alone or combination of estrogen and progesterone, the most commonly used one nowadays is what we call estradiol therapy. Estradiol is the form of estrogen that our ovary makes. So, this is a bioidentical formulation that we typically use. It is most commonly used and one of the most tolerated forms. Another very commonly, and actually one of the oldest forms of estrogens that's available is what we call conjugated equine estrogens. This is probably one of the most studied one. It's used in a lot of randomized controlled trials. And people may have heard about it. It is a form of estrogen that was um, uh, isolated from horse urine samples. And the thing about conjugated equine estrogen, it actually has about 20 different forms of estrogen in it, including estradiol being one of them. Okay. These other two synthetic ethylene estradiol and synthetic conjugated estrogens are also available. Ethylene estradiol, I just put out there as it's the form of estrogen that is commonly used in contraceptive pills and can be used for some perimenopausal patients who are maybe also looking for birth control. And this last one is a little bit of a newer form called estetrol. It's actually another technically bioidentical natural compound that is produced from the fetal liver, but we stop producing it as soon as we're born. But it's an interesting newer form that's out there that does seem to help both for contraceptive reasons, but also for some menopausal symptoms, which is great. I'm going to talk a little bit about how we give estrogen and the most common ways that it's been given. Most commonly, it can be given either in an oral formulation or transdermal, meaning through the skin. There are some pros and cons of both of these options. I'll be very honest, the vast majority of us providers do favor a transdermal route. And the reason for that is when you take estrogen orally, it has to go through your GI system and actually be metabolized by the liver. When this happens and this liver metabolism happens, you can actually get an increase in some cholesterol levels. You actually can also get an increase in clotting factors, and you have a little bit more cardiovascular effect on that. When you use it through the skin transdermally, you bypass all of that. And so you don't have that increase in cholesterol, increase of clotting factors, meaning that your clotting risk with transdermal estrogen is a lot lower. The interesting thing is also when they looked at it from like what we call a pharmacokinetic standpoint, meaning like how we absorb it and metabolize it, the estrogen levels seem to be a little bit more stable and a little more even keel when you take it through the skin as well. And then we should talk a little bit about progesterone. So why do we need progesterone if estrogen is really the culprit to help us with our menopausal symptoms? It's because we need it to protect our uterus if we have not had a hysterectomy. The lining of our uterus really requires a very delicate balance of estrogen and progesterone. When there's an imbalance, meaning we have more estrogen and it outweighs the amount of progesterone we're giving, you can actually begin to grow lining in your uterus, and it can be growing in an abnormal way. So the first thing that happens is you start spotting or bleeding if you don't have enough progesterone. If really uncontrolled, can start to actually develop polyps. And then if very uncontrolled, you can actually develop certain precancers or cancer of the uterus, which is something we very much want to avoid. And so that's why you really need that good balance of progesterone with your estrogen. There are a few different progesterone options. The most common one that is used is micronized progesterone, or MP. It's a bioidentical form of progesterone that our body makes. And it is usually formed in the formulation of like an oral capsule. Okay. I'm going to circle back. I will warn everyone because I do think this is an important point, is that micronized progesterone is made in peanut oil. And so if you have a peanut allergy, which is very common, please be aware of that, and you would need to look to find a little bit of an alternative, which I'll talk about later. The other form of progesterones that are available are what we call progestins. These are other chemical compounds that are from progesterone, like precursors, that when we take them in, they then get broken down into progesterone itself. They are a little bit more potent. And so the reason that that's kind of important is if somebody, for example, is perimenopausal and having a lot of heavier bleeding as part of their changes, this is like a really good, potent way to both control people's cycles as well as give them the uterine protection that they need in case they also want to get some estrogen for their menopausal symptoms. I've listed a few of the names that your provider may bring up, and a lot of these can also be found in some forms of birth control, but again, given at very different doses for this reason. How to give progesterone, the most commonly used is by taking it orally at night with micronized progesterone. The reason it is really popular is one, it is bioidentical. but also actually has a little bit of a sedating effect because of the way that it is metabolized not only in our body, but the receptors it acts in our brain. And so, it also has a little bit of a nighttime anti-anxiety effect. So patients really love that, especially if they're having some sleep problems. I will stress it is not a sleep aid, but it is like a nice potential side effect that can really help as well. It can be taken nightly, as I mentioned, but for some patients who may not want to take oral progesterone every single day, you can take it kind of like part of the month or talk with your provider about alternative kind of cyclic ways you can take it. Another way that can be used is you can actually use a progesterone, specifically levonorgestrel IUD, commonly brand names known as Mirena or Liletta. There are some combination patches with both estrogen and progesterone, but I will say they none of them have micronized progesterone in them. And there's just a little bit more limitations on the amount of estrogen that are in those patches. What I do have to say, unfortunately, is that there isn't a topical form of micronized progesterone that has yet met the kind of strict requirements for what we call uterine protection or endometrial protection. So that's what I mean by talking about that like balance. Um, they're trying to work on it. They're trying to find some forms because people do want some transdermal forms, but unfortunately, we just don't have that yet that we know is shows long-term safety data that you are not going to get abnormal growth inside the uterine lining. So I just want to take a really couple of moments just to talk about things to think about when you are talking to your provider about what are the risks really about menopausal hormone therapy. It's very important to talk and bring up with them like what is really a risk and what's not really a risk. So the biggest one that I always bring up with patients is just technically estrogen is pro-clotting. And so that's the biggest risk that's associated with estrogen. That being said, again, we favor transdermal routes of estrogen so that we can decrease that clotting risk. There are some thoughts about the risk it does have on our cardiovascular system, but again, this is very nuanced. It matters how you're taking it, when you're starting it, how long you're on it. So really talking about what your provider about like what truly are the cardiovascular risks that are associated. Interestingly enough, we have a really cool webinar tomorrow with through the Menopause Society about the metabolic risks associated in menopause and hormone therapy, if anyone ever wants to check that out. And then lastly, everybody's always going to always asks me about the breast cancer risk. And so really understanding, are you in a place where this might increase your risk of breast cancer, or are you in the general population where really the risk of breast cancer that is associated with menopausal hormone therapy is less than 1%? So having that conversation with your provider, I think, is really important as well. Okay, just some very brief prescribing principles that many of us do follow. It is all about the individual. Not everybody starts the same way. It's not like it is not a cookbook recipe for prescribing hormone therapy. We have to identify what symptoms are the most bothersome. What are your concerns? What are your goals? And what may put you at risk for using hormone therapy if you have any severe risk for that. We tend to start on the lower side and build up. But again, it's not just you, oh, everyone always starts on the very lowest. Again, it can depend on the severity of your symptoms. The other thing is just knowing how this works in terms of expectations. It can sometimes take as long as 10 to 12 weeks for people to notice a difference. And then adjustments can be an iterative process, meaning, we may adjust, go up, come down if you're feeling like it's too much, that kind of thing. So really, it has to be an individualized way to approach. Just very quickly as well, I talked a lot about this transdermal kind of form of estrogen. The most common form that people use are in the form of patches. I just wanted to throw out there are things like sprays, gels, and vaginal forms of estrogen. And then just take 2 seconds to say, unfortunately, right now, we don't have any safety data about the use of hormone pellets right now, mostly because they're just not well studied in terms of their stability. And we do know that just small millimeter differences in the size of the pellet can really throw off someone's hormone levels. And so right now, still not really recommended. Who knows what will happen in the next several years, though, if that gets a little bit more work and research on it. There are a number of non-hormonal medications and options for patients if they don't want to talk about hormone therapy. We do talk a little bit about lifestyle modifications, including, nutrition, exercise, stress management, sleep, disruptions, all of that. And I will say lifestyle modifications can help the severity of menopausal symptoms. They're not, I will be honest, they're not going to treat them, though. They're not going to make them go away. Again, they may bring them down a few notches, but it is a really helpful thing for patients that they can do in conjunction with other therapy if that's the way that they want to go. I do talk to my patients about supplement options as well. We talk about the pros and cons of supplements. And I do find that they may be good for a lot of patients with more mild symptoms who may not want to go down the full hormone therapy route. And there are some non-hormonal pharmaceuticals as well. There are a couple of medications in the antidepressant, anti-anxiety medication family that have been shown to help patients with some of their menopausal symptoms. And I'm going to talk in the next second a little bit about two newer generation medications that have come out as well called NK antagonists. So this family of medications, kind of bringing us back a few slides here, we talked very briefly about how estrogen plays a big role in our thermal center in our brain. And there is this family of nerves around the thermal center that have little receptors on them called NK receptors. And so when estrogen has dropped low and these little receptors are now open, that thermal center goes just firing off. This new generation of medications actually come in and block those receptors. So what's awesome is that these were medications really created for the menopausal patient. They're not other medications that just happened to also work for patients' symptoms. This is what they were designed for, which just shows a shift in the, the attention that the menopausal transition really needs. They have really been shown to reduce the significant vasomotor symptoms. So again, our hot flashes and night sweats. There is some really incredible data coming out about how much they can also be helped with sleep disturbances related to menopause. The two brand names that are out there right now are called Veoza and Linkuit. It is worthwhile bringing up with your provider as well. I know I bring it up with my patients as viable options as well. So I want to take this kind of end here towards the presentation, a little bit about some buzzwords that are out there, explain what some of these buzzwords, even some of them times I've used a little bit as well. The first word that I want to talk about is bioidentical. I have referenced it a little bit, and it is definitely out there in the news, social media. And so just taking a moment to kind of understanding what that actually means. And bioidentical really means these are hormones that are chemically and molecularly identical to the hormones that our body produces. And when we're talking about this in reference to hormone therapy, we're really talking about the hormones that are produced by our ovaries during the reproductive years. It unfortunately has turned into this kind of like marketing term to kind of imply that it's more natural, safer, to kind of sell products. Well, a lot of the examples that I was giving as well are actually fit into this category. And there has been this kind of overlap between the next buzzword that I'm going to talk about, which is that people think that bioidentical automatically means something called compounding. Compounding and bioidentical mean two very different things. Compounding is like a pharmacy term where at specialty pharmacies you can actually mix different types of medications, whether that's hormone therapy or others, into kind of individualized batches rather than compared to a commercially available product. The problem we have with a lot of compounding pharmacies, not all of them, but a lot of them, is they're technically not FDA regulated for things like impurities or require any proof of claim that commercially available products are required to prove. The biggest downside, however, and especially that I find for compounding, is that it's not covered by insurance when commercially available products are. And so I just want to stress that like bioidentical and compounding are two kind of very different things. One is about how it's mixed. The other is how it's molecularly structured. And so really kind of understanding that with what your provider will recommend, I think is important. There are some situations that I do find that compounding is really necessary. And again, this is why an individualized approach is really important. You may need to individualize dosages that are not commercially available for patients because of intolerances or otherwise. There may be allergies or intolerances to what are in the commercial products that are not the actual hormone, for example. I gave the example before about micronized progesterone. It's made in peanut oil. And so patients with a nut allergy, I actually have to get it compounded from a specialty pharmacy in olive oil so that patients can use micronized progesterone. So again, it's really about knowing when to do certain things as opposed to just having like a blanket statement for everybody. And then using a reputable pharmacy. So ask your provider on what their practices are, when they compound, and where they get it from, and if there's any way to get insurance to cover it. I'm just gonna maybe Heidi, I can give you some of these slides about the resource options for patients as well. That way, if people want to access these kind of like last few slides, I just wanted to kind of show that and then open it up to questions. The first is the Menopause Society, which I'm a part of. They have not only professional resources, but a lot of patient education. You can find out and find providers who are certified menopause practitioners. And really, this is kind of like an independent society that is really focused on evidence-based medicine to really improve patient health and healthcare experience, especially during the midlife as well. There's also the International Menopause Society, who, it's not just about what we're doing here in the United States. There is amazing work going on all over the world. They also have a really great online presence where you can watch other webinars, short podcasts as well, and they target not just hormone therapy alone, but also how, a little more individualized or unique populations and their menopausal transition. The NIH does have a small presence as well, and you can look up My Meno Plan, where you can actually input your symptoms, look and see what options may be recommended, print it out, bring it to your provider, have a discussion with them as well, which is kind of a nice resource to have. And then I can't ever go on without speaking about Women Living Better. This is an amazing website, really about really understanding perimenopause, trying to get, understand, see if that's what you're really experiencing, and giving you information, support groups, all of that. There's a little bit of like a forum that you can talk with other perimenopausal patients about your experience. There's no products, no kind of fear-based messaging on Women Living Better, which is amazing. And it even taught me a lot when I was going through my own education about the menopausal transition. Mary Claire Haver is also a really great resource as well, and her books are really amazing. So, I'm very thankful for how great she's been about getting out there and talking about the menopausal experience. Kelly Casperson as well has a lot about like sexual health and stuff like that that I wish I could talk about today. Maybe we can do that at another time as another webinar about libido changes and testosterone, which I wish I could talk about today as well. But again, that might be a conversation for another day. Um, and then I'll give a little bit about some of these books that are out there as well that may be a nice little guide also into the menopausal transition. Thank you so much for your attention and just like wanting to get more information and educated about menopause. And hopefully I can answer some questions if there are any in the Q&A.
Yeah, we do have one question. For how many years do your patients stay on menopausal replacement therapy? And do symptoms get better or only for some people?
Amazing question. So the median number of years that patients will say that they continue to feel menopausal symptoms seems to be about 7 to 8 years, meaning the most number of patients who reported menopausal symptoms say that their symptoms last for that long. So that's not even the average. The average is probably could be a little bit lower, which is kind of a little misleading. So the most number of patients say that they'd last about 7 to 8 years. So there may be some different philosophies around this. In general, we think about keeping patients on from somewhere for about 8 to 10 years, because the vast majority of patients at the 10-year mark will actually have their symptoms almost completely resolved, which is great, right? We do think that the worst of this is really during the transition and that a lot of the symptoms do peter out in the later postmenopausal time. That being said, there is about maybe between 10 and 20% of patients who have menopausal symptoms who have them longer than that, and a small subset who have them lifelong. And so when you are thinking about staying on it or coming off of it, it should be a weaning process. So we'll have patients drop down their estrogen dose a little bit, stay on that for several weeks, see if their symptoms return. Do the same thing again, keep going lower and lower. And then if their symptoms haven't returned, awesome, they're not on it anymore. But this is a way to determine if your symptoms have fully gone away, or are you in that small subset of patients that it may last longer or potentially lifelong. What we have noticed research-wise is that if any of the symptoms are really going to persist, the one that tends to be the most persistent one tend to be the hot flashes and the night sweats. And so most of the other symptoms do get better, especially the brain symptoms, it seems from the research that we have seen. That being said, also, I'll give this last little caveat about that is, there are some symptoms that do have a little bit of overlap with natural aging and not just menopause alone, because we do see that some of these changes in patients who don't have ovaries. So it's always good to kind of take that into consideration. For example, the joints and the arthritis and stuff that can happen with natural aging. And so, it's really kind of like sussing that out as well and making sure that you are addressing that, not just from a menopause standpoint, but also from an orthopedic standpoint, for example. But usually our philosophy tends to be somewhere around the 10-year-ish. But again, it has to be individualized with your provider.
Thank you. And why the weight gain? Like why
Oh, yes.
and can the can hormone replacement therapy prevent the weight?
Amazing question. Amazing question. So what happens both with it's a mix. The weight gain part is definitely a mix of menopause as well, unfortunately, with natural aging, because we do know both in those with and without ovaries that in general metabolism slows down with older ages. So we know that naturally. That being said, estrogen does play a role in like fat deposition, as well. We all talk about a lot of the weight gain tends to happen in like the midsection of our bellies. And that is because estrogen plays a role in how we deposit our fat stores. So what I unfortunately have to tell patients is that menopausal hormone therapy is not a weight loss medication. It's not going to make people lose weight. What it can do for some patients, not everybody, because our body types do matter. Some patients on menopausal hormone therapy may report a little bit better response to diet, exercise modifications that are made for us in our midlife. And some patients may notice maybe a little bit better about fat composition, meaning that like they're not losing the weight, but that maybe it gets redistributed in a little bit of a more even way. But unfortunately, we have not seen menopausal hormone therapy, cause weight loss. I wish, but it unfortunately doesn't.
That's too bad.
It's really
We
unfortunate.
have another question.
Yeah.
Let's see. Do you recommend women stay on HRT for bone, skin, hair health, even if they are no longer having hot flashes and other like sleep symptoms?
This is, I will be honest, a little bit of a controversial topic. So I will be very transparent that you may get different answers about this. Um, for bone, if you are in a very high risk category, there may be some benefit. It's not 100%, but there may be some benefit on staying on it. So our patients who have like these very high risk factors, especially for osteoporosis, very bad family history, very low weight, low muscle mass, all of that, there may be some benefit. That being said, it only prevents bone loss. It's not going to make you like regenerate new bone, unlike some of the other osteoporotic medications that are available. Staying on it for just hair and skin alone, we just don't have the like best topical forms quite yet. So, it is really about understanding the risks of staying on it beyond into the older ages because some of the risks that they did see associated with hormone therapy, when we're talking especially about like the heart health, the clotting risks, all of that, it does tend to creep up in the older ages. And so, it's really about like risk benefit analysis about whether or not you are getting that and how much it's affecting your quality of life. So I don't know if I can say it's recommended to do that, honestly. It's very different if you're having a symptom that is like drastically affecting your quality of life, like, the brain fog and the night sweats and the hot flashes and stuff like that. Yeah, I mean, if you're still having them, there's a benefit to staying on it. And again, I apologize, not to say that like our skin health and our hair health, like it's important to us and important to me too. I just don't know if it's very much worth the risk that do tend to creep up a little bit in the later years.
Great.
I'm hoping they're going to find some sort of topical estrogen form. There were a couple of studies about, again, I'm not advertising that people should do this, but like they did look at some studies about of people who are using their vaginal estrogen along their face and neck. But I think only it was like a very low percentage of patients actually noticed responses. I think it was only about 25 to 30% of patients who applied it to their skin. The issue is like getting it actually absorbed. I think with the vast majority of topicals, like certain creams, um, even for like just other forms of skin health, skincare, it's really trying to get it actually absorbed. And so I think I just don't think they've gotten a formulation yet that's great for the skin.
Super helpful. Any other questions? I think you might have answered all our questions. That was so thorough, so helpful.
All right. Well, thank you so, so much for having me. Again, I can't stress enough. I have barely scratched the surface today. And
Well,
then
we'll definitely plan some other presentations.
would love that. Would love that.
So thank you so
Um,
much, Dr. Sharuk.
Absolutely.
And I also just want to remind everyone that we will be posting the recording on the JCC Greater Boston website. So you'll be able to watch the presentation again. I can also share out the resources that you listed in your presentation. I would be happy to do that. And then if anyone has any questions about JCC Greater Boston's programs, you are welcome to email me. My name's Heidi White, and my email is hwhite@jccgb.org. Thank you so much. Have a
Thank
great evening.
you. Have a great evening.